Hey guys, how are you? Welcome back. For those who have been following us, thank you so much. We've noticed, some people have been subscribing. We really appreciate that. And we hope you like this next case that we have today. This is from my internal medicine job. And,
Not me this time.
Yeah. And this is a case about a young man with multiple comorbidities. So let's get on with it. This is a 38-year-old male, past medical history of high blood pressure, high cholesterol, and diabetes, the top three. He's on losartan, he's on simvastatin, and he is on metformin and januvia. Okay, so
he's on a cocktail.
Yeah, he came to us as a new patient. So he has no surgical history, no allergies. He's a non-smoker, social drinker. Has family history of cirrhosis on his mom's side and breast cancer. On his dad's side, high blood pressure. Otherwise, nothing else going on. He hadn't seen his PCP in 10 months, and the last one retired. So he's coming to us now as a new patient, and he's just basically here for an annual screening. He's up to date with his maintenance exams, like ophthalmology and podiatry, since he's a diabetic. But otherwise, he's doing pretty well, asymptomatic, no complaints during this visit. So,
So what do you know? So, I haven't done an annual physical since my family medicine rotation.
Yeah.
From what I remember, you just normal physical. Labs. If you're 40, you get an EKG. Cardiac history.
Exactly.
So, what do you?
Nothing has changed since you've been through your family medicine rotation, and your physical exam is still the same. So, especially with this guy, because he has multiple comorbidities, you want to make sure you get all the labs that are pertinent to his comorbidities.
So, for this guy, you want to do lipid panel, an A1C, and that's about.
And this is stuff that you do for most people. So you do a CVC, BMP, A1C, lipids.
Yeah. If
they're over 45, I do a PSA. Of course, they have to be male for that. But yeah, so for this guy, very basic stuff. Okay. His vitals were stable. Physical exam was unremarkable aside from him being markedly obese. His BMI was 32. But yeah, otherwise nothing going on. So we did the blood test, we did urinalysis, sent him home. Results take 2 days. So when the results came back, I called him, and there were some things that were mysterious, let's say. So in terms of pertinent comorbidities, right? So at the time of, like I said, the vital signs were stable. So his blood pressure was stable at the time of the exam.
That's well controlled.
Yeah. In terms of his cholesterol is 190, should be under 200. So controlled.
Yeah.
LDL is 110, slightly elevated, should be under 100 given that he's a diabetic for stricter controls. His HDL was 60, which was actually pretty impressive for this guy. His trigs were 180, they should be under 150, so he needs to improve his diet a little bit. And
don't we all?
Yeah. And his A1C was 6.7.
That's not
terrible, controlled. You want it to be under 7.5 for diabetic, obviously under 6.5 for non-diabetics, technically under 5.6, if you want to consider them 100% non-diabetic. Yeah. And the thing that stood out to me was the AST and the ALT. AST was...
Why did you do a hepatic panel on this guy?
I just get a CMP.
Okay.
Yeah. So just, we get that. Plus he has high cholesterol, so he's on statins, which means you have to monitor their LFTs anyways. But yeah, I get CMPs for most of my patients anyways. It doesn't hurt. You're getting a BMP, might as well get a CMP. It's cost efficient and
it's the same draw.
Exactly. So
tell me, what was with his LFTs?
And so his LFTs, his AST was 102. His ALT was 109. Both should be under 40, depending on which normal values that you look at, but they should be under 40, and this is about 2.5 times normal value.
What were his billies doing? His alk-phos wasn't his gallbladder.
Yeah, so his alk-phos was normal, and billies were normal too. So in terms of other hepatic panels, everything else was good.
Just as ALT, AST.
Correct.
Elevated.
Yeah.
That's interesting.
Yeah. So, what you thinking?
So, right away, I'm thinking just about liver pathology. You know, one of the more common things is alcoholic cirrhosis. You said he was a social drinker, but what is social to me versus what is social to you versus what is social to this guy?
Yeah.
We can rule that out. I think you should think about, obviously, the hepatitis is not very common, but could be.
More common than you think, actually.
Yeah?
Yeah.
I guess I only see the hep Bs that need removals.
Yeah.
Obviously cancer.
Yes, definitely. Especially given his family history, his mother had cirrhosis.
Yeah. Did he know what it was? Did he tell you, my mom was a heavy drinker, or?
So she was not a heavy drinker. So it's non-alcoholic cirrhosis.
Okay.
Yeah.
You said this guy was morbidly obese.
Correct. Yeah.
So fatty liver.
Fatty liver.
Yeah, but why don't you?
Yeah, so you got it right. So the first thing you want to rule out, especially with a young guy like this, is alcoholic.
Yeah.
Because that's such an easy diagnostic. And you can just rule it out. Boom. Next thing you want to worry about is, again, he takes statins.
Statins.
You want to make sure medication-wise. So statins will increase LFTs. Steroids increase LFTs. What else? Amiodarone increases LFTs. And, he's a male, but estrogen can also increase LFTs. And so can methotrexate. So, you're going to ask if they have RA or any,
But he had...
We know his medical history. Other, liver pathologies that can increase this is Wilson's. Something, we forget. Autoimmune hepatitis. Alpha antitrypsin. Hemochromatosis can also increase LFT. So you want to be aware of these. So brought the patient back, because we had to talk about it. In terms of, so the first thing we want to rule out is alcoholic.
Yeah.
And he, strongly denies that he takes any or drinks excessive alcohol. He takes about 2 to 3 cocktails, he said, per weekend. So
that's not awful.
Not excessive. And he said, I asked him about Cage negative. He's not an alcoholic. I asked him about herbal supplements too, because a lot of times you don't know what's in these supplements and they're not FDA regulated. So you never know what they're taking. And so
what it's actually doing.
It's always a good question. It's always a good thing to ask about any supplements that they take over the counter, which this guy didn't. The next thing we wanted to do was rule out, like you said, hepatitis. So Hep B, Hep C. Did another blood test to rule out for those serologies. Also did coags, because again, the liver. Iron studies. And, got all those results back. All of them were negative. Hepatitis was negative. Iron panels were normal. And coags were normal. So at this point, you're like, okay, basically everything that I'm thinking is not coming up. And so you kind of go back and think about this patient holistically. And then you say, okay, his mother had cirrhosis. He has metabolic syndrome, essentially, right? He has high blood pressure, high cholesterol, diabetes.
Wide waist.
Yeah. His BMI is 32. We'll talk about metabolic syndrome quickly. So, impaired glucose.
Yeah.
So, glucose over 100. They must have high blood pressure. So, I think with the new category, criteria, it's 130 over 85. Elevated triglyceride levels, so over 150. Low HDL levels, under 40. And like you said, abdominal obesity, which means a waist over 35 for males and 32 for females.
Oh.
Yeah.
So, let me just ask you a question about metabolic syndrome. So,
Oh, also, sorry, before, it must be 3 out of 5 of those to be categorized. And this guy is definitely 4 out of 5. Maybe 5 out of 5. We don't know his actual waist, so like.
You didn't measure?
No, I did not measure his waist.
Yeah. So my question about metabolic syndrome: say his triglycerides were within normal limits, being on all these statins and everything. Say his HDL was a little low, but his glucose was well managed with his metformin and januvia. So the fact that he has diabetes and hyperlipidemia, does it count as a marker for metabolic syndrome, or is it if those values are uncontrolled?
If those values are uncontrolled. I mean, sure, you can look at it both ways, but the fact that his values are controlled is because he's on medication. Yeah. Not because he doesn't have the underlying disease, right? So you have to take both that into account. So you take a look at the whole picture, and it kind of matches up with, fatty liver disease, also very prevalent because of our Western diet.
And his obesity and hyperlipidemia and.
Right, exactly. So we decided to do an ultrasound, and the ultrasound showed diffuse increase in echogenicity and vascular blurring consistent with fatty infiltration.
There you go. I was like, okay.
Fatty infiltration, fatty liver disease. So this guy had fatty liver disease. Surprisingly, very, very prevalent. NASH is the most common cause of isolated elevated liver enzymes. Its prevalence is approximately 16 to 23% in the United States alone.
I believe it.
And
I think it's probably higher.
Yeah, and what's more even surprising is like 2/3 of people with a BMI over 30 have NASH. And so if you can imagine how many people over the BMI of 30, how many patients do you see over a BMI of 30?
Service.
Well, that is an outlier, obviously. But it's crazy, right? Yeah. Like you wouldn't expect that whatsoever.
So you said about 20% or so of people in America, patients in America, have non-alcoholic fatty liver disease. Mm-hmm. So why don't we talk a little, just because I think that number is probably a little more, that number is more likely to be higher, just patients aren't identified, just because it doesn't really harm you except for your liver enzymes. In order for somebody to catch it is to do a CMP or to get liver enzymes, So why don't we talk about identifying patients who may be at risk? Because it seems like the way you caught it was a simple blood test, which patients are getting on the regular anyway.
Yeah, I mean, so you're right. Like initially, it's hard to diagnose it because there are a lot of ways you can go about it. And someone, especially with a bunch of comorbidities, you're likely to think of something else, something more dangerous, to rule it out first, as opposed to NASH. Not saying NASH is not dangerous; it can lead to cirrhosis, which is why it's relevant. But you kind of hit it on the nail earlier, where you said, it's associated with metabolic syndrome and very strongly. And like we mentioned, 2/3 of people who have a BMI of over 30 have NASH. So very likelihood to look at their comorbidities and kind of deduce your diagnosis from that standpoint with isolated LFTs.
So let me ask you, if you have a patient who has hyperlipidemia, hypertension, diabetes, and is obese, would you automatically get an ultrasound for them, or would you wait to see if there's a difference in their liver enzymes?
Yeah. You definitely want to wait for the LFTs. Go from least invasive to most invasive. If they don't have LFTs, there's no need to get ultrasound. Mm-hmm. Ultrasound is essentially to confirm your diagnosis. Even though, so let's talk about that. Ultrasound is the best initial imaging modality for NASH, for fatty liver disease. However, like we said, with every ultrasound exam, it's variable on the person doing the exam. So the best test is doing a liver biopsy.
Okay.
And that will kind of determine your prognosis and your treatment afterwards. No, and notice how I didn't say NASH, because the only way to differentiate non-alcoholic steatohepatitis from alcoholic steatohepatitis is doing a liver biopsy. And the treatment for non-alcoholic steatohepatitis, as you may guess, is to treat the underlying disorders.
Yeah.
So for him, stricter controls and high blood pressure. His blood pressure was within normal limits, so we didn't have to worry about that. His cholesterol could have been in better, stricter control. So we increased the dose of his statin.
Now, let me ask you a question about that, because statins also affect your LFTs.
Yeah.
So by increasing your statin dose, are you then not having a completely reliable LFT response? So say you increased it and his cholesterol came down, but his LFTs were still high. Is that now because of your newly increased statin dose? Or is that still in line with fatty liver getting worse? That's
kind of like the chicken and the egg. But there's no contraindication whatsoever to giving statins with elevated LFTs from non-alcoholic steatohepatitis, because you're treating it.
Okay.
Per se.
Yeah.
Right? And then his, we didn't have to change his diabetes meds because, again, he was within the
below
normal,
7.5.
Exactly. Through research, the only things that have showed to control non-alcoholic steatohepatitis is, number one, lifestyle modification, so exercise, diet, and weight loss. Those are the three most important things you can do to decrease your LFT levels.
And exercise, I think they're the most undermined.
What's that?
They're the most undermined or underrated when you try to advise your patients.
Yeah.
That wasn't the best thing you can do.
Right.
Is change your diet, go to the gym, shed off those last couple pounds. And they kind of roll it off their shoulders or just want a pill.
Right. And in terms of medications, the only thing that has shown to improve LFTs and liver biopsy both has been orlistat, which is a weight loss medication.
Okay. I don't know if I've heard of that.
Orlistat?
No.
Okay. We can talk about it some other time. And ARBs.
Okay.
Two medications that have shown to improve liver histology and LFT levels.
So, let me ask you a question. If somebody is on an ACE inhibitor,
correct,
and their blood pressures are well controlled, they're well managed, would you then...
I would switch into an ARB.
And they're found with...
Yes. I would switch into an ARB, because because ARBs have shown to have a better improvement on LFTs than ACE. So you want to switch them to ARB, even though ACE is controlling their blood pressure. Okay. And, the most important thing here is the reason why NASH is prevalent, because it can lead to cirrhosis. So it's a precursor to cirrhosis, and as we know, cirrhosis is no good, which is why you prevent it. So very important to have stringent controls on their comorbidities, and like we said, diet, exercise, weight loss. Three most important things you can do for NASH. That's a lot.
Yeah, so let me just kind of bind everything together. Yeah. Okay. So this is a 38-year-old male. His history of diabetes, hyperlipidemia, hypertension. Here for the annual physical, found on the annual labs to have elevated LFTs. You suspected liver pathology, sent him out for an ultrasound that came back with fatty deposits within the liver parenchyma.
Yep.
That diagnoses him with NASH,
It diagnoses him as steatohepatitis. We deduced it as NASH because we figured that the patient was reliant. Yes.
Okay. So with that, you went up on a statin. You left his diabetes medications the same. He was already an ARB, so you left his hypertension medications the same. What's his follow-up?
So for these patients, we want to have them follow up closely. So I do every 3 months.
Okay.
And then continue to trend their LFTs. As long as they're going down, that's great. However, if within a year you're not able to get the LFTs under control, even if they're decreasing, I typically tend to do a hepatology referral.
Okay.
Yeah. Just
this guy.
This guy, I haven't had him back in 3 months yet. This happened like a month ago. But yeah, we'll see. Maybe we'll do an update when he comes back in 3 months and kind of
follow him through.
Exactly. That's it, guys. I hope you enjoyed this. And
thanks for tuning in.
Yeah, we'll have some new cases next week.
Remember to like and comment and subscribe. That way you do know when we have new videos coming up.
Exactly.